Hello, you're welcome to my platform. I am Dr. Sandra and I'm a surgeon. I help you become aware and sensitized about the different surgical conditions. Today's video is about a congenital band. A congenital band results from an abnormality in the formation of the umbilical cord, and it is usually as a result of the failure of the disappearance of a structure called the vitreointestinal duct after its closure or obliteration. This abnormality usually occurs during fetal development when the unborn child is still in the uterus. In order for us to understand what happens in this condition, we have to understand how the umbilical cord is formed. Everything starts from the stage of fertilization, when the sperm fertilizes the egg in the ampulla of the fallopian tube. After fertilization, the fertilized egg has to transition to another stage called the stage of cleavage, where it undergoes cell division to form a cell mass called a blastomere, and it contains 8 cells. This usually happens around day 2 after fertilization. At around day 4, the blastomere has to transition to another stage called the morula. The morula is a result of cell division, continuous cell division, where the blastomere now has to continue dividing into other cells. The cells can multiply up to around 16 to 32 cells, and this entire cell mass is called a morula. Once in the uterine cavity, the morula has to go to another stage called the stage of blastulation. During this stage, the morula has to undergo several cell divisions to form a cell mass called a blastocyst. The blastocyst has 2 cell layers. It has the inner cell layer called the embryoblast and an outer cell layer called the trophoblast. At around day 7, the blastocyst has to transition to another stage. That is the stage of implantation, where it gets attached to the walls of the uterus, specifically the inner wall of the uterus called the endometrium. During the stage of implantation, the outer part of the blastocyst, that is the trophoblast, has to divide into 2 cell layers. That is, it has the outer part, the outer cell layer called the syncytial trophoblast and the innermost part called the cytotrophoblast. Now it is the syncytial trophoblast that digs deep into the endometrium, the walls of the uterus, the inner wall of the uterus, allowing attachment of the blastocyst onto the endometrium, that is the uterine wall. By day 12, the blastocyst has to transition to another stage, and that is the stage of bilaminar disc formation. During this stage, the inner cell mass of the blastocyst, that is the embryoblast, has to divide into 2 cell layers, that is the epiblast and the hypoblast. At day 14, these 2 cell layers, the epiblast and the hypoblast, grow in such a way that they form fluid-filled cavities above and below the midline of the blastocyst, respectively. The fluid-filled cavity formed by the epiblast is called the amnion, and the one formed by the hypoblast is called the yolk sac. By the 3rd week of gestation, when the unborn child is still in the uterus, the epiblast forms a layer of cells called the extraembryonic mesoderm. This layer of cells lines the inner lining of the trophoblast. The extraembryonic mesoderm will later form a connection between the embryoblast and the trophoblast, and this connection is called a body stalk. The body stalk is one of the components of the umbilical cord. At around the 3rd week of gestation, when the unborn child is still in the uterus, the embryoblast will transition to another stage. That is a stage called gastrulation. This means that it will have 3 cell layers instead of 2 cell layers. This process usually starts by formation of a structure called a primitive streak on the surface of the epiblast. After formation of the primitive streak, we shall have the first wave of movement of the cells of the epiblast through this primitive streak. And these cells will move in a way that they will enter deep into the embryo, displacing the hypoblast, and these cells form a cell layer called the endoderm. After the cell layer that formed the endoderm has migrated, we shall have another cell layer that will migrate from the epiblast through the primitive streak, and this will occupy the place between the endodermal cell layer and the remaining part of the epiblast, and this will form a cell layer called the mesoderm. And so the remaining part of the epiblast will form the cell layer called the ectoderm. So you can see that by the end of this process of gastrulation, we have three cell layers. We have the endoderm on the inside, we have the mesoderm in the middle, and then we have the ectoderm on the outside. So each of these cell layers will form the different parts of the body. For example, the endoderm is going to form the gut tube, which is going to be divided into the foregut, midgut, and then the hindgut. It majorly forms the gastrointestinal tract. It is also responsible for the formation of other organs, for example, the pancreas, the liver, and the gallbladder. Still at the third week of gestation, when the unborn child is still in the uterus, the embryo is going to undergo folding in a craniocaudal fashion. That is, it will fold on this side where the head is supposed to be, and also this side where the buttocks should be. So it folds in that direction on both sides, and this also causes folding of the endoderm, the inner cell layer. That inner cell layer that was initially formed, that was first formed in the gastrulation phase, is going to also be folded into a gut tube. And this gut tube has three segments. It has a foregut, a midgut, and a hindgut. While the endoderm is being folded into a gut tube, the yolk sac will as well be folded, and it will also form part of the gut tube. And part of the yolk sac will be left connected to the midgut of the gut tube that has been formed. The connection left between the gut tube, that is the midgut, and the yolk sac is called the vitreointestinal duct. The vitreointestinal duct is the second structure that forms the umbilical cord. Still at the third week, at the hindgut part of the gut tube grows a pocket, an outpouching, and this grows into a structure called the allantois or the allantoic duct. The allantois or the allantoic duct is a structure that drains the urinary bladder. The allantoic duct or the allantois is the third structure that forms the umbilical cord. So you can see that we have formed the three structures that form the umbilical cord. These three structures that we have so far formed, that is the body stalk, the allantois or the allantoic duct, and the vitreointestinal duct, together with the two umbilical arteries and one large umbilical vein, form the entire structure of the umbilical cord. At the fourth week of gestation, when the unborn child is in the uterus, the amnion also undergoes folding. Remember that the amnion was formed by the cells of the epiblast. The cells of the epiblast grew and formed a fluid-filled cavity. So it is now this fluid-filled cavity that was formed by the epiblast, the amnion, that now grows downwards to envelope the rest of the embryoblast. The folding of the amnion kind of brings all the structures of the umbilical cord together, and it also forms the outer lining that covers all the structures together, that is the body stalk, the allantois, the vitreointestinal duct. So at the end of the day, we have a fully formed umbilical cord. And by the 7th week of gestation, when the unborn child is still in the uterus, these three structures, that is the allantois, the body stalk, and the vitreointestinal duct, are going to emerge through the abdominal wall of the fetus, and they are going to emerge through a small opening called the umbilical ring. as the structures composing the umbilical cord. The other structures that will also compose the umbilical cord will include one large umbilical vein and two umbilical arteries. At the end of week 7, there is a disappearance or a shrinkage of the vitreointestinal duct and the yolk sac. Failure of the closure or the shrinkage or the disappearance of the vitreointestinal duct or the yolk sac can result into certain conditions. For example, the congenital intestinal fistulas, the umbilical adenomas, the mucous diverticulum, the intra-abdominal cysts, and the congenital bands. At around the 8th week of gestation, when the unborn child is still in the uterus, the allantois or the allantoic duct is also meant to close off, disappear, and shrink. And this leaves behind a remnant called the urachus. If the closure does not happen, we can end up with a patent urachus, meaning it is going to be left open. And this can result into certain conditions. For example, the urancofistulas, the uranchosinuses, the uranchocysts, and the uranchodiverticulum. In a setting where the vitreointestinal duct was completely obliterated, it was completely closed off, but it didn't disappear, meaning that it is going to be left connected to the umbilicus and the ileum, the last part of the small intestine, we shall end up with a condition called a congenital band. A congenital band will present as features of intestinal obstruction, for example, on and off abdominal pain, abdominal distension, vomiting, failure to pass stool, and failure to pass flatus. The investigations that we carry out in congenital bands include serum electrolytes. We can also do a plain erect abdominal x-ray. We can also do an ultrasound scan of the abdomen and a CT scan of the abdomen. When it comes to the treatment of the congenital bands, we usually carry out a procedure called an explorative laparotomy plus band ligation and resection. An explorative laparotomy means that we open up the patient's abdomen and we look out for the band. And once we find it, we do what we call ligation. Ligation means that we tie at the end where it is connected to the umbilicus, and also we tie at the end where it is connected to the ileum, the last part of the small intestine. And after that, we do what we call resection. Resection means that we cut. So we still cut at the end where it is connected to the umbilicus, but a little bit further away from where we tied. And also the end it is connected to the ileum a little bit further away where we had tied initially. So the take-home message is, please be on the lookout for any features of intestinal obstruction, for example, on and off abdominal pain, abdominal distension, vomiting, failure to pass stool, failure to pass flatus, as this can actually point to a possibility of a congenital band, especially in children. Once you see these presentations, I highly recommend that please bring your child to the hospital, as this can prevent complications. For example, ischemia, that is a reduction of blood flow to the intestines, and this can result into the death of the intestine, a condition we call gangrene. And after that, the intestines can form a hole, that is, it can perforate. And once that happens, the patients can get other complications like shock, where we are going to have a reduction in their blood pressures, and so the amount of blood that goes to the vital organs, for example, the brain, the kidneys, and the heart, is also going to be reduced, and the patient can easily die. So it is very, very important that you bring the children once you see these presentations, the first time you see the presentations that I've just detailed. Yes, that is what I had for you. Thank you so much for listening to me. Please share my videos and also subscribe. See you in my next video. Bye.